The purpose of this program is to provide you with a better understanding of the medical diagnosis that was given to you or someone you know. This program does not provide specific medical advice. The information it contains should not be interpreted as a recommendation for a specific treatment plan or course of action, and cannot replace the advice of your own physician. What is right for any one person is an individual decision. You should consult with your doctor, who can discuss your needs, symptoms, and treatment.
Our medical director, Dr. C. Everett Koop.
We can plan for and anticipate many things in life, but a health concern is usually not one of them. What I have learned over the years as a physician, as the Surgeon General of the United States, and as a patient, is that understanding a health problem can make a real difference. Over the next 30 minutes, we will take you through the very issues you are probably wondering about right now. By the end of our program, you will have the knowledge you need to better understand what you or a loved one is faced with and what can be done about it. No matter what challenges lie ahead, it helps to be knowledgeable and to stay informed. So stay with us, because we're going to help you do just that.
Hello, I'm Linda Ellerby. Migraine and other severe recurring headaches can devastate people's lives. But in most cases, changes in lifestyle and medication can bring relief. Our program is made up of 4 different reports about headaches. In Report 1, we look at how different types of headaches are diagnosed and what is going on inside the head that may cause the pain. In Report 2, we discuss what happens next. You'll learn about what kinds of healthcare professionals you may encounter. You'll also learn about lifestyle changes that may bring relief. Report 3 explores options for treatment and management. And finally, in Report 4, we address issues that frequently arise. We'll be giving you a lot of information. To review it, use the booklet that comes with this program. You'll also find a place to write down questions and take notes when you're with your doctor, and a list of other resources that are available. Now, our first report.
Report 1. Understanding the diagnosis.
It's like something pressing and it won't stop.
I just sometimes felt like if I could just amputate my head, that the pain would go away.
More than 90% of us get headaches. Most are fairly mild. But some headaches are so severe and frequent, even disabling, that they require medical attention.
It's been estimated that as many as 50 million people in the United States suffer from headache alone, and a large number of those suffer from migraine headaches.
It's a common disorder that is the leading cause of absenteeism from work. Kathy Scarella, an operating room nurse, simply cannot assist in surgery when she is herself in excruciating pain.
My hearing is affected, sight is affected. I can't take bright lights. I couldn't be sitting here now talking to you. Sound is intensified, and all you want to do is be in a dark room with the covers over your head, and I cry a lot.
Kathy has the classic symptoms of migraine, one kind of primary headache. Doctors use the term primary to refer to headaches that are medical conditions in and of themselves, not symptoms of other diseases. In addition to migraine, there are 2 other kinds of primary headache, cluster and tension type. Each has its own distinct symptoms.
If they have nausea and vomiting and sensitivity to light and noise, we call that migraine. If the eye droops and tears and these attacks occur nightly, we may call that cluster. If it's a band-like headache without a lot of associated symptoms, we call that tension-type headache. Tell me about the bad headache you had a couple of weeks ago.
Well, I had forgotten how bad they truly could be.
To better understand a patient's headache, doctors will ask a lot of questions, and they often do tests checking vision, hearing, reflexes, muscle strength, and balance. They may also ask that you have a CT scan or MRI to get a detailed picture of the brain. These imaging tests are not necessary to diagnose headaches, but doctors may order them to rule out more than 300 conditions, from thyroid problems to tumors, that can cause headaches. Most important, when making a diagnosis, doctors consider a person's symptoms.
To diagnose migraine, what you're looking for is several things. You're looking for a history of a headache that's intermittent, meaning it's not an everyday headache. Typically, we look for a one-sided pounding or throbbing headache, usually with some sort of gastrointestinal upset. And that may range from as mild as not feeling like eating to as severe as nausea and vomiting.
And that headache may last anywhere from hours to, in some people, days.
Even though migraine has been observed through the ages, the basic cause is still unknown. But researchers believe it can be traced to an area within the brain. All the functions of the body are controlled by the brain. A vast network of blood vessels surrounds the brain. These vessels supply oxygen-rich blood, which the brain needs to function. The brain controls and monitors the rest of the body through nerves. It sends messages out through nerves telling the body how to function. Nerves also carry messages such as pain from the body back to the brain. Taking a closer look at the brain, we see that nerves also communicate with the vessels surrounding it. Like the rest of the body, the blood vessels need to receive instructions from and send messages to the brain. Migraine is believed to result from the relationship between the blood vessels and nerves. One theory involves a large nerve called the trigeminal nerve, which is located at the base of the brain. Some branches of the trigeminal nerve go to the arteries of the brain and surrounding tissue. A disturbance in the trigeminal nerve, or the area around it, triggers a reaction in the nerve endings around the blood vessels. The nerve endings release substances called peptides. This causes the blood vessel wall to become inflamed and swollen. The vessels also expand. These changes cause the vessels to throb as blood moves through them, sending pain messages through the nerves to the brain. The result is a migraine headache. Now, this is just one theory. There's still no definitive explanation for migraine. Experts do know, however, that migraine can be set off by triggers that can vary from one person to another. Some may suffer migraine after a change in the weather. Others may respond to stress or certain foods. And in women, fluctuations in hormone levels can be a trigger. We also know that migraine tends to run in families. 70% or more of sufferers have at least one close relative with the disorder. Patty McMiller has had migraine headaches since she was 11. Her son Chris started getting them when he was just 8 years old.
The biggest drawback we had with Christopher's wasn't the severity of the headaches so much as it was the frequency. And he was having headaches 3 or 4 times a week.
About a quarter of migraine cases begin in childhood, when the condition occurs equally among boys and girls. In adolescence, when the menstrual cycle begins and hormone levels start to rise, girls become more vulnerable to migraine. Eventually, in adulthood, 3 times more women than men suffer migraine headaches. For both women and men, migraine takes 2 basic forms, with and without aura. An aura is a forewarning, usually striking within an hour before a migraine attack.
The most common problems that people will have is they may lose part of a field of vision. For example, they may notice they can't see out of one part of their eye. They may notice what's called a scintillating scotometer, or bright flashing lights that move across the visual fields.
Other patients may develop a sensory aura, typically numbness, which begins in the fingertips or the toes and then spreads to involve greater parts of the body and then subsequently resolves.
Another warning sign of a migraine is called a prodrome. A variety of symptoms can occur long before the headache itself begins.
So that patient might, for example, have a food craving, may become elated or silly or giddy, might become excessively tired, might become very depressed or angry. Perhaps they will have a change in their bowel habits. They might have nausea or vomiting or diarrhea or abdominal cramps. And that period of time may last 24 or 48 hours prior to the actual onset of the headache.
Migraine is so disruptive that a chronic sufferer is very likely to seek medical help. But the other kinds of primary headache can send someone to the doctor's office as well. Barbara Hall sought help because her tension-type headaches were interfering with her job as a bookkeeper.
Most of the time it's just like a band around my head, like just the tightness across my forehead on both sides.
Tension-type headache, the pain is more both-sided, not one-sided. It's not throbbing. It's more like a squeeze, ache, or pressure. Almost like a hat band around the head, or a skull cap type of phenomenon is another way of describing it.
If that sounds familiar, it's because tension type is the kind of headache most of us get. Doctors are not certain what causes it, nor do they know what causes cluster headaches. Cluster headaches are the least common, but they can be the most painful type of primary headache.
The headaches are always one-sided. They are virtually always located behind one eye, sometimes radiating into the jaw or teeth. Unlike migraine, cluster sufferers can't sit still. They pace the floors. They wrap their heads against the walls. They go for walks in the snow wearing nothing but gym shorts and a T-shirt.
Ben Getty can relate to stories like that.
People say, oh, it's a headache. It's not a headache. It's like your brain is exploding. That's how bad it is.
No matter which kind of primary headache is plaguing you, it doesn't have to stop you from enjoying life. There are steps you can take to cope with, and in some cases, prevent headaches. We'll talk about them in our next report.
Report 2. What happens next?
Well, Jim, tell me a little how you're doing. How have you been doing?
Well, I've had some reoccurrences.
Often a generalist physician, a family doctor, or internist will supervise your care. In some cases, you may be referred to a headache specialist, such as a neurologist or psychiatrist. Some patients go to a headache center. Here, a team of healthcare professionals coordinates a patient's pain management program.
What I'd like you to do is try to keep a headache diary on the days that you experience a headache.
Todd Allman is working with a nurse educator to determine whether there's a pattern to his migraine attacks.
Nurse educator can be helpful in instructing patients about the importance of keeping a headache diary, noting the frequency and intensity and duration of their headache events, helping to identify triggering factors.
Sometimes those triggers may be things in the environment, like bright light, strong odors, or change in altitude or air pressure. You can't do much about these. It may also be difficult to manage the hormonal fluctuations that are a factor for many women who get frequent headaches. But many other triggers can be identified and avoided. Food-related triggers may include aged cheese, chocolate, red wine, food additives such as MSG and nitrites, and a sudden decrease in caffeine. Triggers related to behavior include skipping a meal, sleeping late, or not sleeping enough. While many of these triggers are most often associated with migraine, they can be a factor in other primary headaches as well. When Fred Ruffino started getting treatment, he learned that many of his favorite foods and drinks were contributing to his chronic cluster headaches.
I love my martinis, I love my scotch,
It's one of the worst things if you have cluster headaches. Aged cheese was a total disaster for me, and I never realized that.
And all headache sufferers may find their pain is linked to something very difficult to get a handle on: stress, and the letdown after stress. Stress is probably the most common headache trigger, and it can be aggravated by the headache itself. Veronica Mitchell's headaches usually start at work. When she brings them home, they also affect her family, and that adds more stress. Her daughter, Amir, can tell right away when she has a headache.
She just wants to come home and go to sleep, so we have to, take on her responsibilities.
Veronica's husband, Gerald, is glad she sought treatment because she can join the family after work instead of heading to bed.
Children need attention. Even husbands need attention.
It's really a family disease, and I've had patients sit in here and cry about the guilt they feel over how their family has to live around their headaches.
In some cases, patients and their families see a mental health professional, such as a psychiatrist or a psychologist.
Sometimes you can identify a food trigger by filling out a headache diary.
Some people with headaches also find it helpful to join a support group where participants can exchange information and coping strategies.
You just remember these things that you've gone through, things that have helped, things that don't help. And when you come to the support groups, you can share that with other people. And maybe if you can just help one other person.
Everybody's in the same boat. And when you talk to other headache sufferers, you don't feel like you're burdening your spouse or your children.
If you're like many headache sufferers we talked with, you may find out you have to talk to your family and to your employer about your need to make time to see a doctor and other health care professionals. Your particular condition and treatment will determine how many appointments you'll need. Generally, more visits will be necessary at first, and then they'll decrease over time. It's important for family, friends, and coworkers to understand that though your headache cannot be seen, it is a real medical condition.
Most of the people with headache have been passed off as being complainers, people who have no pain tolerance, people who have emotional difficulties, people who are dependent, people who are neurotic, and all of that is really hogwash.
We've talked about prevention, identifying and avoiding the headache triggers you can control. Avoiding triggers doesn't mean you can always escape headaches, however. For many people, medication is a part of pain management. That's the subject of our next report.
Report 3. Treatment and Management.
Bye, Barbara.
Successfully managing migraine and other primary headaches requires a continuing partnership between you and your doctor.
I tell every one of my patients that migraine is not a disease we cure. This is not like having a strep throat and you take 10 days of some medicine and it's gone. It's a disease that we manage. And management can take a pretty broad spectrum of events, really.
Treatment for headaches typically begins with over-the-counter pain medications, such as acetaminophen or NSAIDs, which stands for non-steroidal anti-inflammatory drugs. Aspirin is an NSAID, as are ibuprofen and naproxen. These analgesics, or painkillers, are called simple analgesics because they contain a single ingredient.
If those don't help, then you can move on to the combined analgesics, which usually contain caffeine in them.
But taking too much of any pain relief medication can be dangerous, and it can actually lead to more frequent headaches in some people, called rebound headaches.
In other words, the more painkillers a person takes who has headache, the more likely they will have more headaches. And if they're taking those painkillers and not seeing getting proper care from a physician, they will actually stand a very good risk of making their entire headache process worse.
As is the case with all medication, over-the-counter painkillers can have side effects. NSAIDs in particular can cause gastrointestinal problems in some individuals. When over-the-counter treatments don't help, the next step is often more powerful prescription medications. For migraine, There are two broad types of medications your doctor might prescribe, so-called abortive and preventive drugs. Abortive medications are aimed at stopping migraine attacks once they begin. They're often prescribed for patients who have infrequent attacks or mild symptoms. The most widely used are called ergotamines. These work by constricting the arteries. Ergotamines can be associated with nausea and vomiting, so your doctor may prescribe them with an anti-nausea drug. Another abortive drug with fewer side effects is sumatriptan. It is injected or taken by mouth.
Okay, here we go. You're gonna feel
It works by preventing the enlargement of certain arteries in the head or reducing inflammation in pain-sensitive areas.
Sumatriptan has as its greatest attribute the speed with which it works and the number of patients who get this rapid relief. For most patients, in 20 to 30 minutes, their migraines are relieved. And it works for probably better than 80% of people who use it.
Some patients experience minor side effects. Because abortive drugs constrict blood vessels, they're usually not given to people who have cardiovascular disease or who are at risk for it, nor are they prescribed during pregnancy. The second category of medications prevents migraine attacks. These include beta blockers, calcium channel blockers, and antidepressants. Calcium channel blockers may also be prescribed for cluster headaches, and antidepressants can be effective against tension-type headaches, even if the patient does not have depression. Each of these has side effects which should be discussed with your doctor, who can help you weigh the benefits against the possible side effects.
In other words, you may have somebody who's done very well on medication, and their headaches are much better, but they're very tired, or they feel depressed, or they can't exercise as well, or their interest or ability to perform in sex is down. So, you really want to look at what the trade-offs here are.
As part of your overall approach to managing headaches, you and your doctor or nurse educator might explore various types of relaxation therapy. These can range from simple breathing exercises to biofeedback.
What I'm going to do is hook you up.
Biofeedback helps people learn how to regulate some bodily processes they don't ordinarily control, like muscle tension, blood flow, and the temperature of the skin. As patients relax, the biofeedback machine records those changes.
Things like biofeedback and relaxation therapy can be just as helpful as medications in the right patients.
Marcia Shannon found help for her migraine headaches through a combination of therapies.
I've never felt so in control of my physical state as I do now, that I have the tools that I need in order to control the migraines.
Through effective treatment and management, many other chronic headache sufferers are able to gain the same sense of control.
Oh, I feel great. I feel terrific. This year was a good year. I've gotten on with my life. I'm not existing, I'm living now, which I wasn't doing before.
Report 4. Issues and Answers.
Had I discussed this with my family doctor sooner, I'm sure I would have gotten treatment sooner, treatment that helped me control my headaches better, and would have definitely improved the quality of my life.
It isn't always easy to know when or how to discuss things with your doctor. Here to talk about issues and answer some of our questions is Dr. Kenneth Welsh, chairman of the Department of Neurology at Henry Ford Hospital in Detroit. Thank you for joining us.
It's a pleasure to be here.
Dr. Welsh, knowing what to say to the doctor can be difficult. What advice can you give us about talking to the doctor?
Prepare yourself before you go to see the doctor. The doctor will ask you 4 very general questions. How long have you had the headache? Have you had it for weeks and days, or have you had it just for a few hours? What makes it worse, or what makes it better? Keep a diary so that you can help the doctor know better when this is happening. And also tell the doctor where on your head the pain is occurring. And finally, prepare to tell the doctor what it's doing to your life, because quite often the pain will make you go to bed or disrupt your sleep, and that's important for the doctor to know how you are dealing with it.
Earlier we mentioned that antidepressant medications may be effective against some headaches. What's the connection between headaches and depression?
In a small proportion of patients with migraine, depression will begin before the migraine headaches begin. And in another equal proportion, they will occur after the headaches have begun. And the fact that antidepressants make the patient better, however, has very little to do with depression. It's really acting on the brain itself to help the pain of migraine.
We've also said that no one is certain what's going on inside the brain that causes migraine. And you've been doing research on this. What have you learned?
Well, we've heard what happens probably to cause the pain of the migraine attack, but we really don't know what causes migraine itself. We think that the brain may be overexcited at certain times, and this causes nerve cells to fire off and then go to sleep for a period of time, and then this activates the pain. Now, why those nerve cells should be overexcited, we still need to study.
Something else we've discussed is that fluctuations in hormones can be triggers for some women. Can you elaborate on this?
That's very true. In fact, of course, migraine is 3 to 4 times more common in women than it is in men. And then it may begin the same year as you have the first period. It may be very closely timed with the menstrual cycle. It may go away when the patient is pregnant and may become totally erratic during menopause.
So do certain medications that involve hormones, birth control pills, hormone replacement therapy, increase the chances that some women will have headaches?
Sometimes, in some patients, the birth control pill or estrogen replacement treatment makes it very much worse. That's usually because the dose of estrogen given is a small dose, and the levels in the blood keep going up and down. And when they fall all of a sudden, that seems to cause the migraine attack. So what is needed is either not to take them or else to have a somewhat higher dose, so that they can indeed make migraine better under some circumstances.
In general, what is your message to people with headaches?
Well, migraine is part of you. There is no cure for migraine, but we can control migraine. And because migraine is part of you, you are an important part of the treatment. Your own observations about what makes your migraine better or what makes it worse are very, very important to the doctor and to you. It's teamwork between you and the physician.
Dr. Welsh, thank you for joining us.
It's a pleasure.
And thank you for joining us. Remember, you can use the booklet that comes with this program to review key points and to take notes. You'll also find a resource guide and a glossary of terms that may be helpful. That concludes our series of reports on migraine and other headaches. We wish you well.
I hope we have done our job and that you are better informed. The knowledge you have gained should help prepare you for decisions you may have to make. It can also help you sort out any additional information you receive, whether it is from well-meaning friends or the evening news. Facing what you or a loved one is going through right now involves taking personal responsibility. Responsibility for keeping in touch with your doctor and other health professionals and for following their instructions. And of course, responsibility for getting the support you need to cope with certain issues. For all of us with Time Life Medical, thank you for turning to us at this time in your life.
To help you access important information that was covered in this program, you may refer to your personal workbook. You may also find additional information related to your situation in other Time Life Medical videos.